Hello and welcome back to Count to 10. Today is a very special episode because it represents the end of our respiratory physiology topic, and what we're going to be covering today is measurement. Now, when you come to the end of respiratory physiology, it feels like you've achieved a massive milestone. Respiratory has so many things to cover, and it's so mentally taxing and such a mental hurdle just to get through it. What I can say is that life does get better after respiratory, and you start to feel yourself get into the flow of how to be able to cover learning objectives quicker and more efficiently. The other announcement I have to make is a bit sad, and that is that I'm going to start studying for my fellowship exam. Now, doing these podcasts has been amazing, but there's a lot of work that goes behind the scenes to make one episode. Unfortunately, I can't keep doing that same amount of work and giving you guys content that I'm happy with while trying to study for my fellowship at the same time. I just don't think that's fair on you as the listener, but I've come up with a way in which I think we can change these podcasts going forward. So instead of covering one section of a topic per episode and having a pretty linear format in what topics we were going to cover when, I'm instead going to release smaller podcast episodes that just tackle one isolated learning objective and the SAQs associated with that. My plan is to make these episodes 10 to 15 minutes long, and instead of having an order in which learning objectives I'm going to cover, I'm going to leave it completely up to you guys. So if you feel like you're struggling with a learning objective and you want me to cover it, or simply just a learning objective you want to just recap on, send me an email through at anirudh@sweetdreamsanesthesia.com, and I'll review that learning objective and release an episode for it. This way, I can still give you guys good content, because the last thing I want you guys to do is compromise on the way you're studying and not have good quality information. If everything goes to plan, hopefully I'll be finished my fellowship exam next year, and then we'll be back with our normal pattern of going through sections as per previous. So with that in mind, let's get into our topic today, which is measurement. And really, we've covered majority of these learning objectives throughout our previous episodes already. There's only 2 more learning objectives to cover, and a few important SAQs both from the ANZCA and the ICU exam. This is definitely a nice and relaxed way to finish respiratory physiology, especially after some grueling episodes we've had covering applied respiratory physiology and VQ relationships. So let's stop wasting time and dive straight in.
1, 2, 3, 4.
Now, our first learning objective is interpret blood gas analysis in respiratory failure. This learning objective overlaps with acid-base physiology, but I do think there is a few fundamental things about acid-base that's important to learn early, which will make reviewing acid-base physiology a lot more easier. We know that the lungs have a big part to play in controlling acid-base, and the reason is quite simple. There's approximately 10,000 millimoles of carbon dioxide that are excreted through the lungs every day, and if we compare this to the kidneys, which only have the ability to remove 100 millimoles of fixed acids per day, you can see that there's a 10-fold difference in capacity between the lungs and the kidneys. So a change in alveolar ventilation will have a huge role to play in our body's normal pH status. Now, fundamentally, everything boils down to 2 key equations in terms of respiratory failure and respiratory acid base. The first one is Henderson-Hasselbalch equation, which links pH to pKa and the log of an acid and its conjugate base. The second equation is the equation that we know, which is water plus carbon dioxide makes carbonic acid. This then dissociates into bicarbonate plus a hydrogen ion. Now the key is, how do we link these 2 equations together? Well, there's complex steps that happen in between, and you don't need to really know about these complex steps. If you do want to know, there's a beautiful explanation west that goes through this step by step. But essentially, our end equation is that pH is equal to the pKa plus the log of bicarbonate divided by carbon dioxide. Now we know the normal values of bicarbonate being 22 to 24, and we know that the normal values of carbon dioxide within the arterial blood is approximately 40 millimeters of mercury. We also know that carbon dioxide obeys Henry's law, and that the amount of carbon dioxide can then be calculated by the partial pressure of arterial CO2 times 0.03. So plugging this into the equation, we get that pH is equal to the pKa of this buffer system, which is 6.1, plus the log of bicarbonate, which is 24, divided by 0.03 times 40, which gives us 1.3. So therefore, the pH is equal to 6.1 plus 1.3, which is where we get our magic number of 7.4. So how does this relate back to respiratory failure? Well, if we change our partial pressure of carbon dioxide, say that we double it from 40 to 80, we can change our pH from 7.4 all the way down to 7.1. In the same way, if we hyperventilate to, say, bring our CO2 down to 20, we can increase our pH all the way up to 7.6 to 7.7. The key thing I want to demonstrate here is that little changes in our carbon dioxide concentration have a huge impact in our overall pH. This relationship between pH, CO2 and bicarbonate is commonly shown on a Davenport diagram. Now, Davenport diagrams are complex, but on the x-axis they have pH and on the y-axis they have bicarbonate. You do need to be able to quickly look at them and understand what they're doing, because you can be shown them in a viva setting. Now, getting back to the actual physiology and getting back to respiratory acidosis, this is defined as an abnormal primary process in which the PaCO2 rises to a level higher than expected. There are lots of causes for this. A simple cause can be a decrease in alveolar ventilation, or there can be an increase in carbon dioxide production, or there can be an increase in the inspired carbon dioxide that we're breathing in. The physiological effects of respiratory acidosis can be divided into system effects. So on the respiratory system, there's a stimulation of ventilation via our activation of chemoreceptors. On the cardiovascular system, there's an increased activation of our sympathetic nervous system drive, which leads to us being tachycardic as well as sweating. There's peripheral vasodilation due to the direct effect of carbon dioxide, but this is usually offset by the increase in sympathetic nervous drive causing vasoconstriction. In the central nervous system, we have cerebral vasodilation, which can lead to an increase in our intracranial pressure. There is also at high levels, when CO2 gets above 80 millimeters of mercury, we can start to get CO2 narcosis occurring, where there's a depression of our central nervous system. The other major effect is the change in our oxygen dissociation curves. This gets shifted to the right to increase our ability to offload oxygen at the tissue level. And these are some of the main system changes that occur with acute respiratory acidosis. Obviously, our body has compensation mechanisms, and these compensation mechanisms can be thought of as acute or chronic. Mainly, our acute compensation mechanisms are intracellular buffers, and our chronic compensation is via the kidney, which takes around about 2 to 4 days to fully optimize. This is delving too much into acid-based physiology, but there is some important laws or rules you should know with respiratory acidosis as well as respiratory alkalosis. The easy bedside law or rule you should recognize when you're faced with someone in respiratory acidosis is being able to determine whether it's acute or chronic. So in the instance where your CO2 rises, you should have a compensation which allows bicarbonate to increase. In the acute setting, an increase in carbon dioxide by 10 millimeters of mercury will lead to an increase in your bicarbonate concentration by 1 millimole. In the chronic setting, that same increase in your carbon dioxide leads to an increase in your bicarbonate concentration by 4 millimoles. An acute respiratory alkalosis, where there is a 10 millimeter decrease in our CO2 levels, you'll get a 2 millimole decrease in your bicarbonate, and in a chronic setting, it'll be a 5 millimole decrease in your bicarbonate. So for respiratory acidosis, the numbers to remember are 1 and 4, and for respiratory alkalosis, the numbers to remember are 2 and 5. Now that pretty much covers as much as I want to talk about acid-base today, and it moves us to our final learning objective, which is describe the methods of measurement applicable to anesthesia, including clinical utility, complications, and sources of error, with particular reference to a forced expiratory volume, a peak expiratory flow rate, a vital capacity, a flow volume loop, and FRC and residual volume. Now some of these terms we've already covered, but we'll just go through them step by step. The first one is the forced expiratory volume. Now this is very simple to do and can be done using a spirometer, and the main reason you do this is that it gives us an indication about airway resistance. It helps to differentiate between obstructive and restrictive lung disease, and it produces a curve of volume versus time. So on the y-axis you have volume in liters, and on the x-axis you have time in seconds. The technique is quite simple and it's easy to reproduce. You take a maximum inspiration to total lung capacity, then the subject exhales as hard as possible, completely to the residual volume, and this is recorded, and that's what our forced expiratory volume curve looks like. There are really 4 important numbers that we get from this curve. The first one is our forced expiratory volume over 1 second. The second one is our forced vital capacity, which is our total lung volume of gas exhaled. Then we have the ratio of our FEV1 over our FVC, which in normal healthy people should be approximately 80%. And the last important value we get is our peak expiratory flow rate. So this can be done using this technique or a handheld device that people can take home. But essentially it's measuring the maximum airflow rate during a forced expiration from full inspiration. Now in a normal healthy patient, looking at our normal numbers, our FEV1 should be around about 4 litres, our FVC should be approximately 5 litres, and our ratio should be approximately 80%. In the obstructive pattern, what we can relate the changes to is going back again to those time constants. Our airway resistance has increased dramatically, so we're not going to be able to expire the gas as fast as possible. So we have a major decrease in our FEV1, and we might also have an overall decrease in our FVC. However, the proportion of decrease is much more in the favor of a decrease in our FEV1 than it is the FVC. And that is really the telltale sign of an obstructive pattern. Compare this to a restrictive pattern where you get a simultaneous decrease in our FEV1 and our FVC, which leaves our ratio pretty much the same. Just the overall numbers are smaller. So to summarize our forced expiratory volume, we have the ability to detect obstructive lung disease, and typically here we'd see a marked decrease in our FEV1 and a minor decrease in our FVC. The reason is our elastic recall of our lung is decreased, our airway resistance is increased, and therefore the time constant to allow expiration is much more slower. Common conditions that can cause this are things like COPD or asthma. On the other hand, we can have restrictive lung disease, where we get a simultaneous decrease in our FEV1 and our FVC. Our FVC decrease is more marked, and this helps to preserve our normal ratio of 80% of FEV1 over FVC. Causes of this kind of pattern can be things like interstitial lung disease, or obesity, or weakness in our respiratory muscles. Now, the only other parameter I forgot to mention that you can get with this test is a ratio called FEV over 25 to 75%. This parameter specifically examines the mid-flow rate or the forced expiratory flow measured in the middle half of expiration. And the reason I mention this is that it's a sensitive index of small airway function that can be occasionally reduced even when our FEV1 is normal. So it's thought of as a more sensitive marker for picking up airway obstruction. Now moving on, we have our peak expiratory flow rate. We've kind of already described what it is, but it can be handheld monitors that people can take home, and it's measuring your peak expiratory flow rate just like the name suggests. Asthmatic patients can use this easily at home, so if they feel like they have an asthma exacerbation happening, they can do the test, get the number, give themselves salbutamol, and do the test again to see a pre and post therapy effect. So it's a tool for both diagnosis and to check treatment response. Now we'll move on and talk about our flow volume loops, and by far this is probably the most likely thing you'll be asked about. So the flow volume loop is obtained by a closed circuit with a pneumotachograph. The flow rates are integrated with respect to time to get a volume, and they produce a shape that looks like an upside down ice cream cone. So on the x-axis you have the lung volume all the way down from residual volume to total lung capacity, and on the y-axis, instead of having volume, you have flow rate. So that flow rate can be in mils per second or it can be in liters per second. When you first look at this shape, it's quite deceptive, but the inspiration part is the bottom part of the ice cream cone, and the expiration part is the top part of the ice cream cone. Now, to be able to produce this curve, you have a maximum inspiration from total lung capacity, then you have a maximum forced expiration to residual volume, and you just repeat that process, and then this is continuously recorded to produce this flow volume loop. This loop can give us information about both inspiration and expiration, and so we can divide looking at this loop into those two sections. We'll first look at the expiratory phase, which can then be broken up into two more subsequent phases. The first phase is this effort-dependent part. So this occurs at the start of expiration, where you're reaching your maximum flow rate of expiration. This expiratory flow rate is proportional to the intrapleural pressure that you're generating, the inspired lung volume. The higher your lung volume, the stronger the energy that you'll generate to create a higher driving pressure, and your lung compliance as well. Now remember, our airflow rate is determined by our driving pressure, which is the pressure gradient between our alveolus and our mouth. This is influenced by our muscular effort of our respiratory muscles, our size of our inspired volume, and our lung compliance. At the same time, anything that affects airway resistance will also therefore affect our airflow rate. So our airflow rate will be affected by driving pressure and airway resistance. So going back to our flow volume loop, we have our expiratory phase with our first part being effort dependent. Once we reach the peak, we switch over to our effort independent part. This is a bit harder to understand why it occurs, but it relates to this concept of dynamic airway compression. This is quite a hard concept to explain, but I think what makes it easier to try to understand is by thinking about the lung as a big structure and our airways as another structure. Within our airways, we have a certain pressure, and within our lungs, we have a certain pressure. The pressure within our lungs is our intrapleural pressure, and the pressure within our airways is our airway pressure. Now, if our pressure within our lungs increases, so much so that it increases to the point where it's more than the pressure within our airway, it's going to cause that airway to collapse or be compressed. After that point of compression, the flow rate of gas becomes independent of any driving pressure. So previous to that compression, all that force we had generated to create that driving pressure was making that gas from the alveoli flow as fast as possible. After that compression point, we lost all that force, and now our flow rate has become independent of that initial driving pressure. And that is why you have this second part of your expiratory flow curve, referred to as your effort-independent phase. If you're still confused by this concept, which I was when I first read it, what you can do right now is try to expire out your mouth as fast as possible. What you'll find is that when you expire, you're initially generating a really high volume, but then all of a sudden you can't keep that volume up and your flow rate decreases. That point where you can't increase your flow rate again and it's just decrease, that is your dynamic airway compression point. Everyone has one, and this again refers to this concept of our Starling resistor. We said that our normal driving pressure was governed by our alveolar pressure and our airway pressure. However, we get this compression occurring, and at that point of compression, now our driving pressure is governed by that pressure at that compression site and our mouth pressure. So we have another Starling resistor effect. This point of compression is referred to as our equal pressure point. And again, there's a beautiful graph in West that shows this diagram. This can be a common question as an MCQ, and literally you get that graph from West carbon copied as an MCQ question with some of those numbers covered up, and the question is, what is the number at one of those sites? So how does dynamic airway compression relate back to physiology and pathology? Well, in cases where people might have obstructive lung disease, the point of equal pressure point occurs much more earlier during expiration. This will prolong our effort-independent part of our expiratory curve and give a scooped out appearance of our flow volume loop. And you need to be able to recognize this quite quickly and swiftly if you're shown this diagram in a Viva setting. Now, we spoke a lot about the expiratory part of this curve. The inspiratory part of the curve can also give us some information. It's not as detailed as the expiratory part, but things like having an upper airway obstruction will impede your expiratory flow volume loop. So instead of a nice ice cream cone cup that's curved, you'll get a flat inspiratory curve. You might also get this appearance when you have laryngeal paralysis, or there just might be smaller volumes taken in either obstructive or restrictive lung disease. This brings us to the end of our learning objective part, and now we'll move on and talk about some SAQs. There's only 2 SAQs I want to go through, and the first one is actually from the ICU exam. It was asked in 2007, and it was, describe the acid-base changes that occur with acute hypoxemia. Now, this is the only question that I could find that closely resembled our first learning objective, and the examiner report here said that for you to pass, you need to define hypoxemia, the causes of hypoxemia, the formation of lactic acidosis, the development of hypocarbia secondary to respiratory stimulation, and then explain why there's a decrease in bicarbonate and a negative base access. So to start off this question, you can say that hypoxemia is a decrease in the partial pressure of arterial O2, and as we discussed last episode, this is normally 60 millimeters of mercury or less. There are 4 causes of hypoxemia. This can be due to hypoventilation, diffusion impairment, shunt, or VQ mismatching. Depending on which cause you have, this will either cause a normal AA gradient or a raised AA gradient. So a normal AA gradient will be seen in a hyperventilating patient or a patient that's having a low inspired fraction of oxygen. A raised AA gradient will be seen in a shunt, diffusion impairment, or a VQ mismatch. You can think about the physiological outcomes via systems, or you can think about them as local or systemic. But the main ones you want to say that will happen is that you'll get local vasodilation, so you get a decrease in your SVR and a decrease in your BP. You get an increased baroreceptor response. You get a decrease in your partial pressure of O2, which leads to an activation of your peripheral chemoreceptors. This increases minute ventilation. Severe hypoxemia will cause an increase in our blood flow due to a couple of reasons, one of them being the activation of our sympathetic nervous system. And then the major important thing that this examiner report wants you to say was that you get a development of lactic acidosis as you transition from aerobic metabolism to anaerobic metabolism. The consequence of this lactic acidosis is that you get a raised anion gap, you get a decrease in your bicarbonate as this starts to buffer your hydrogen ions that are starting to build up, your base excess begins to decrease, and then to deal with this metabolic acidosis, you have both acute and chronic compensation occurring. The acute compensation is the hyperventilation, which is trying to develop a hypocarbia to try to compensate for the metabolic acidosis. And then the chronic compensation is the kidneys trying to reabsorb more bicarbonate, at the same time remove more fixed acids from the system. So overall, it's a hard question to answer, and it's certainly different to any other question we've got in the ANZCA exam, but it does relate to the learning objective quite closely, and that's why I wanted to bring it up. Now the next SAQ is from the ANZCA exam, and it was asked in 2017. It was, draw an expiratory flow volume curve obtained from a maximal expiratory effort after a vital capacity breath for a patient with normal lungs, restrictive lung disease, obstructive lung disease, which were all worth 10 marks, and then explain how and why these curves are different in each disease state, which was worth 15 marks. This question only had a 40% pass rate, making it a very likely candidate to be asked again. And the main thing the examiner report kind of pointed out was that you needed to start with a good diagram. So a good diagram includes accurately labeled axes, with additional marks given for labeling the effort dependent and the effort independent parts. Common issues in this answer were incorrect units, drawing 3 separate graphs when they said clearly to draw on one graph, inaccurate values for total lung capacity and residual volume, confusing vital capacity for total lung capacity, and vague explanations of why these curves were different. No marks were given for drawing the inspiratory curve, and that's why I spent most of the time talking about the expiratory curve rather than the inspiratory curve with the flow volume loops. So to start this answer, you would just start with a diagram. So on your x-axis, you would have your lung volume, and you could label this as 1, 2, 3, 4, 5, 6, 7, and say this is liters, or you could label this as residual volume and TLC. I'd label this as numbers because residual volume and TLC change for the obstructive and the restrictive patient. On the y-axis, you can have flow in liters per second, and this would go from 2, 4, 6, and 8. Then you can go into multiple ways to answer this question. I think the easiest way is just to make a table with 3 columns, one for normal, one for obstructive, and one for restrictive. You would draw these 3 curves, and then starting off with our normal curve, we could say that a normal residual volume is somewhere around about 1 to 1.5 liters, and normal total lung capacity is approximately 6 to 7 liters. We would have that effort dependent part and then the effort independent part. And you could explain that the effort dependent part occurs at the start as there is increased driving pressure generated by the muscles, the size of the inspired volume, and by the lung compliance. Then there's the effort independent part. Prior to that, you have your max expiratory flow rate, which is the peak. So the max expiratory flow rate represents the transition from your effort dependent to your effort independent part. And in your effort independent part, you have a linear decrease in your expiratory flow rate. And this is occurring due to the dynamic airway compression, which is changing the gradient of your driving pressure being your alveoli to your mouth to your airway pressure to your mouth. And this is occurring because of the Starling resistor effect and because intrapleural pressure is exceeding the airway pressure. So we're getting compression of that airway at the equal pressure point. Past that compression, flow is now generated as the Starling resistor effect. Now the obstructive graph will be markedly different. The reason it can be obstructive is due to asthma or COPD, but the main changes you see is that you get a change in where your residual volume are, you get a change in your total lung capacity, and you get that scooped out appearance of your effort independent part. So the reason why your residual volume is increased is because you have a destruction of your small airways. So you lose the radial traction and therefore your residual volume is much higher than normal. You also have a decrease in your airway radius, and this causes earlier airway closure to occur. So you get airway trapping occurring, and a combination of the airway trapping along with the loss of the radial traction leads to a higher residual volume. The reason why your total lung capacity is higher is because you have lost your lung elastic recoil. So your lung compliance has increased, but you lost your elastic tissues. So your lung can expand to a higher volume, leading to a higher total lung capacity. And this needs to be clearly stated in your table. Your scooped out appearance of your effort independent part occurs due to multiple reasons. The main one being there is early dynamic airway compression, and the equal pressure point is pushed further down into the airways. And again, this is due to a multitude of reasons, mainly being airway thickening is increased, there's increased secretions, our airway radius is decreased because of the secretions, we have a decreased number of our overall small airways, and we have decreased radial traction. So the pressure of that internal airway to resist the change has decreased, so it's more susceptible to be affected by the change of our intrapleural pressure compared to our normal healthy individuals. Now compare this with our restrictive lung disease that you might see in pulmonary fibrosis or interstitial lung disease. Here we have a decreased residual volume and a decreased total lung capacity. The reason our total lung capacity is decreased is because our compliance of our chest is much more lower. So it's much more harder to try to expand that lung to total lung capacity because it's restrictive. Because of that lung being less elastic and being stiffer, when we expire, that stiffness actually helps to generate pressure that maintains that driving pressure. So it offsets the effects of dynamic airway compression. And so our expiratory curve looks very similar to the normal patient. We also have stiffer airways, which are going to be more resistant to collapse from the intrapleural pressure. And because we're generating that high pressure overall, we're going to have increase of our lung recoil. our airway closure is going to occur at even lower lung volumes, and that's why our residual volume is decreased overall. So to summarize this answer, we have our normal curve. In our obstructive curve, we have both an increase in our residual volume and our total lung capacity. We have this scooped out appearance of our effort independent part. In our restrictive pathology, we have a decrease in both our residual volume and our total lung capacity, but our respiratory flow curve looks very similar to that of a normal person, just at a smaller volume. So this is a very tricky question to answer and actually requires you to interpret quite a lot of different concepts about dynamic airway compression, airway resistance, driving pressure, and then be able to put them in a visual format in the shape of a flow volume curve. So this brings us to the end of our episode and completes our respiratory physiology topic. A huge thank you to everyone that's listened so far and given feedback. We've had nearly over 700 downloads of all of our episodes so far, so I really appreciate all your support and really want to thank you guys for listening. Like I said at the start, I'm just moving on to the phase where I'm going to be studying for my fellowship exam, so I just want to make sure I'm giving you guys good content, and I think the best way I can do that is by changing the way I approach these episodes and just looking at one learning objective that you guys suggest. I hope you guys have found these episodes useful, and I found them really fun making them. And next year, hopefully I'll be back doing the same kind of style. But until then, best of luck with your studying, and we'll catch you next episode. And if you have a recommendation for what topic I want to cover next, please email me at anirudh@sweetdreamsanesthesia.com and we'll tackle that LO.